We do have a question in our chat box here. And so this question's from Donna, and Donna's wondering if there are suggestions for public health to make a connection with people who face barriers. So something like door hangers in the neighborhood, about a pop-up clinic. Like, how do you get the word out? How do you facilitate some of those connections? Anyone want to take a stab at that one? Angela, was that over to you?
No, I was gesturing to Stephanie because I feel like I've been speaking a lot, so I'm being mindful.
Thank you. Stephanie, any suggestions along those lines?
Yeah, no, I'm thinking about this. It's a really great question. I mean, one of the things that we've been looking at too with the role that public health can play is sort of connecting with other parts of the system or other sectors, right, to support vaccine uptake and access. So, for instance, within our Indigenous Primary Healthcare Policy Research Network, we look a lot at the intersection between public health and primary healthcare. So Indigenous-led service organizations in the communities, for instance, play a significant role in and have been in the COVID-19 response, right? So I think connecting with other parts of the system, primary care being first point of contact for many individuals or patients, and how can we think about those relationships and collaborations to support access. Going back to Donna's point about sorry, I was just scrolling back up there again. So thinking about with the pop-up clinics, yeah, I think that's an interesting example, Donna. I don't know if you wanted to maybe share a little bit more about, what your thoughts are around that. And again, Sume and Angela, if you have thoughts on that too. But I guess I'm so inspired by your comment, Angela, about, the around security and policing, that I didn't think about lining up for care and waiting for care in that way. And it's certainly a systemic issue. So I'm thinking about what that experience has been like for urban Indigenous vaccine clinics, right? So for urban Indigenous residents and who, there's Indigenous-led vaccine clinics that are supporting vaccine uptake, but for those who might be going elsewhere, what has that experience been like for them as well? So I think these are such important and critical factors that we need, that often are overlooked and not understood by those making these decisions, right?
And in terms of additionally, I think just from my insight here, Donna, to your comment about in terms of the connection with people who face barriers and public health, is what we have seen in some areas is public health units working with their local community partners and together. And we did that with public health when we were doing testing, COVID testing, is working with the local community partners to then do what I think we call flyering in the deep local. So if it's looking at doing outreach within particular buildings where we know there are high numbers of folks who may not have received their dose, but who are facing barriers in that, essential workers, shift workers, limited access to create time that they can control to access vaccines. So we have gone with a really hyper-local strategy now. So initially there were these large numbers of pop-up in terms of vaccine clinics that were larger events. So you're, immunizing a couple thousand a day, or a couple hundred a day. And in those, publicity was at the local, and those vaccine events were earmarked and prioritized for folks who live and or work in that geography. so not folks who can, fly in and access their vaccine, but for folks, so it was defined for folks living in those geographies or postal codes. And now we're doing a strategy that I call kind of hyper local, where we're doing even a deeper partnership where you may be doing a specific building or a specific neighborhood around a community center to bring vaccines to, in partnership and in collaboration with your public health unit. So that's another strategy, is if you bring the vaccine into communities where there's high need, low vaccine deployment, is to earmark or ring fence the vaccine for that population and or for that geography. And one other organization that had mentioned is the Black Physicians of Ontario, that they have launched a Black Vaccinator initiative whereby they have made themselves available to be vaccinators for clinics that are being lifted up for Black populations specifically. And that has been another way to build trust, because you're getting care from your community if you're Black identified.
Thanks, Angela. And there's some great comments in the chat box here as well, examples from across the country of different strategies for that connection and engagement. And one comment from Carrie I just wanted to speak to was, Carrie said that establishing walk-in availability was something that public health units were variable in their comfort with. And I've been working immunization clinics here in Calgary as a public health nurse, and have been part of logistical planning in public health in the past, and just want to speak to the fact that public health often, we love standards. We love putting things out the same way every time. We love making one orientation package to train 5,000 new nurses in this role. And truthfully, we do a really poor job of adjusting and catering to the needs of the particular community in which we're trying to serve. And the only way to do work from an equitable perspective is to look at the particular needs of each community and adjust accordingly. And so this push for standardization is counter to addressing equity issues. And so public health absolutely needs to be nimble, needs to be responsive, and needs to be willing to adjust and keep adjusting as it goes. And yes, that's more resource intensive, but that is absolutely what's needed to be effective in how we provide care and how we offer services. And so I'd really encourage folks who are working within public health, who are part of our audience today, to think of ways to be nimble, to think of asking for resources that you need in order to do that work effectively, and to think about how you build a staff team that is adaptable and flexible to the needs of its community, which can be a challenging thing to do, and I certainly acknowledge, but is going to be paramount to how we move forward in an equitable way. Sume, did you have anything to add there as well?
No, absolutely agree with your comment, and I see Angela echoing that in the chat box. And I would say that so this desire for standardization, right, is not like, it's not a neutral desire. It's a desire for us, for the whole world, to function by white supremacist, dominant, patriarchal, it's not neutral. So questioning what we consider standard in and of itself, I think for us in public health, is a really great starting point. And then it just helps that most of the things which are standard, they work well for a very small portion of people. Like, they do not work for most of us, which is, I always find very ironic that this idea of equity is not a fringe thing, right? And I think we all know this on the line. Like, if we actually have the systems which, as you're saying, are more flexible, more equitable, they actually benefit more of us a lot. It's not a fringe idea. And I think I just wish our systems would actually acknowledge that. I think it's a really important component. There was a piece which I just wanted to pick up on in the chat box around potential mistrust of communities may have. I think Carrie was sharing this, and to me, it really speaks against the importance of having that work be community-led, community-governed. One thing which came from, I remember speaking to one of the key informants, and the way she phrased that was beautiful, because she said, we're trying to build trust in the vaccine, but not necessarily trust in public health and the health system, right? So knowing that that is it's necessary, but it's really a longer term process, a longer journey, which really is public health responsibility, not community responsibility. So I think in time of a pandemic, it's not time, it's where the relationships exist, is just drawing on those. And I also heard a concern that as this work starts to roll out, public health will want to come up front and say, hey, we did all these amazing things, really, and silence the leadership which communities have been playing. And so I'd say communities are leading, communities need the resources to continue to do that in a way which actually matches the extent of the need and the assets and the desires which already exist. And for us in public health, absolutely continue to build those relationships, but this is not our time to shine. I don't think we've done it very well. So let's let communities do what communities have been doing well. And I remember asking someone a question, so what is the role for public health then? And it's like, you know what, public health needs to support it or get out of the way, right? So either you support the work of communities or say we can't really do this well and we'll just not stand in the way of good work, which I thought, absolutely, that's true.
I just wanted to build on your point, Sumi, if I can add just a few things that came to mind is one of the things that we often hear is, at least in identifying the strengths or those successful examples of what worked well in Indigenous communities, is that, you know, what we hear is that often these examples are not documented. And if they're not documented, those successful stories and examples of those community-led, community-based initiatives are not documented, they're not shared some way. It's as if they don't exist or they don't happen. And I just wanted to raise, I think that's an important thing is, you know, I know all of us with the work we're doing is that's what we're trying to do is being, you know, share knowledge and be able to, you know, demonstrate that, you know, the communities have been doing this for so long, for so many years. They know what resources they need. They know how best to serve and support their communities. And I just want to you know, hopefully use this as a reminder for all of us to draw on those community strengths. The other thing that I think that we all touched on in our conversation today, and it got me thinking a lot about this, is that when we're talking about lessons learned or how can we think about different strategies and approaches that might work well, and what, you know, advice or recommendations to offer to public health, is that a lot of what we're talking about in terms of accessing vaccine equity or vaccine access is not so different from what many of these population groups or communities have historically and contemporarily experienced in accessing the systems, whether it's lining up for care or waiting for care and what happens as a consequence of waiting for care, right? You know, I've been hearing a lot of stories lately of, you know, white individuals traveling to the far reaches of our province, you know, just to jump the queue to get quicker access to that, you know, their second dose, right? And so that makes me think, you know, a lot about the concept of equity here is that, well, they, you know, they're using their privilege to access the vaccine, right, in a quicker way. And that's, you know, as Angela had pointed out earlier, transportation is a big barrier here, right? So is being a, you know, let's you know, acknowledge that distinction too in terms of where, you know, people with privilege, how that shapes their experience, but also their ability to access care quicker. And, you know, I think that lessons really holds true here for this example around vaccine access.
So two things that I wanted to just in terms of attach to this conversation. So one is when you spoke clear about standardization, is the language that I've also heard in some of these vaccine planning tables was standardization around process, efficiency and speed. And that what we want to do is get doses into arms, and that's, you know, the goal here, and always having to be mindful, all of us, when we are in those conversations, is to kind of pause it a little bit, because we know that within the system pre-COVID, like, when is it that standardization, efficiency and speed has resulted in bringing equitable access for marginalized populations, including racialized populations. So efficiency was never, I think, really, its architecture was never really meant for us. So really always wanting to then pause a bit, because one of the things that certainly, and my colleague Cheryl Prescott, the ED at Black Creek Community Health Center, has always spoken to the fact that we may need to go slower and steady to reach marginalized populations. And if we do that, slow and steady, then we know that a slow and steady framework will leave room to respond to those other folks who have less barriers and less challenges. So if you build a system for the slow and steady approach, then it will be a process that will be accessible for others with less barriers and who may not need slow and steady. So just thinking about that from that lens. The other piece that I wanted to, and Claire, you may be heading into this, but I'm also thinking about that the work that we're doing around COVID vaccination efforts and how do we bring vaccination to communities facing marginalization and or access barriers, is that we also need to then think about what are some of the other broader determinants of health issues that need to be enabled to support folks who we are also seeking to bring vaccines to. So when I think about issues of transportation, I think about issues of sick time for essential workers. So I think about why is it that it was deemed that essential workers during the height of the pandemic should get more pay? Or should get some pay incentive, that they should get some time incentive. But then post-pandemic, heading out of the pandemic, is like they no longer need it when their circumstances and their condition has not changed. And why is it that we saw that with CERB, that we identified through CERB that here is a basket of income that we see as responsive for folks to live on, but then post the pandemic, then that level of income is no longer required, but the conditions of people's material conditions haven't changed. So really also asking us, as we think about all of the things that COVID enlivened, I call it as an equity response, are things that I think we need to hang on to dearly, that we say must be maintained as we enter the recovery conversation. So just wanting to throw that on the table. And I know that we may be short on time, but I didn't want to miss this opportunity.
Thank you, Angela. And I think that those are perfect closing words, because I think as we move towards recovery and as we look to planning for future pandemics, because there will be more, how do we hang on to these pieces and not let them go? Because I think it will be very easy to go back to the way things were, which is not a system that has worked for very many people. And so we need to consider these social and structural determinants of health in all facets as we move forward together. So I want to thank our guests today, Angela and Stephanie, for joining Sume and myself in this conversation and bringing forward your amazing expertise and insights and wisdom. And thank you to all of our participants today for taking time out of your day to have this conversation with us, and for all of your great contributions to the chat box and the resources you've provided. We'll be sure to include those in our follow-up email. Thanks to Jamie, who's part of our team and has been plunking some additional resources in there and making sure our tech went smoothly. And wishing you all a very good summer ahead. And I believe it's the first day of summer today, as well as, of course, National Indigenous People Day. So take care, everyone, and take care of yourselves and your communities as we move forward together. Thanks so much, everyone.
Thank you. Thanks, Claire.